Welcome everyone. We'll give you a minute to get situated, and I recommend, if you can, to share your video so we can see everybody. We have a lot joining us today. This is our biggest group yet. Yeah. All right, well, I'll go ahead and start as everyone's settling in. And again, I encourage everyone, if you have, to kind of share your video and be interactive and drop in the chat questions as they come up. We want this to be as interactive as possible. But I want to welcome Carrie, Evan, and AJ. And this is really exciting. We're going to talk about being a climbing PT, which is, we have a lot of questions that were submitted. We'll also answer questions in the chat. We'll go about an hour or so, and I think we're just going to get right to the chase. So I'll just have each of you introduce yourselves. Maybe we'll start with Carrie, and we'll go from there. And Carrie, do you want to introduce yourself and what you do with climbers?
Hi, everyone. My name is Carrie Cooper. I am a rock climber and a physical therapist. I have been in private practice with my own office since 2016. And I've worked on the World Cup circuit. I specialize in working with climbers, and that's me. I'm in Salt Lake City.
All right, maybe Evan?
Sure, yeah. So I'm Evan Ingerson. I'm also a rock climber and a physical therapist. I work in Boulder, Colorado, and I work at a private practice where I see more than just climbers, but primarily climbers. And especially as I've been in this practice longer, I just see more and more climbers until that's basically just about all I see at this point.
And AJ?
Cool. Good evening. I'm AJ Sobrilsky. I live in Bozeman. I work for Excel Physical Therapy, and I'm a Climb Strong coach as well. I would say I specialize in climbers, but I don't solely see climbers. I see probably, it depends on the week, but a lot of mountain athletes who are also climbers, but I also get a good taste of the specific climbing athlete, which is pretty unique. Yeah, that'd be me.
All right, so we have a lot of questions. I think this one would maybe go to each of you. The question was essentially, how did you get into seeing climbers or treating climbers? And I know each of you probably have, maybe a different or a similar story, but whoever wants to kind of jump on that one, because people listening, I'm sure many are treating climbers, but the percentage that you treat and the amount that you see on a daily basis, kind of how did you get to that point or that stage?
I can start if you want. Yeah, so for me, I think it gradually grew. I was already a PT when I started climbing, came in from a different kind of sporting side of it. And in the community I was living in, was in the gym frequently. People knew me as kind of the running PT back then in Flagstaff, Arizona. And as I started just being in the crag more, going out more, being in the gym more, kind of making that connection, people started to know me as that kind of person within the gym setting. So it kind of grew from there. And then when I moved to where I live now, it was definitely connecting with a lot of the people that work at the gym, the setters, the people that work the front desk. They're all really good climbing partners and friends, and again, just getting some exposure that way. So doing nights at the gym, doing talks at the gym, just being available and sharing information that way. And I think that slowly kind of helped just build up that amount of people. And now through Climb Strong, and get a chance to work with some of the coaches through there and talk to a lot of climbing athletes just everywhere now, which is great.
Cool. I can go next. So I started in the insurance-based world, just treating like general orthopedics, and then I got the opportunity to go up to this private practice in Boulder. And I actually went to this practice without the intention of being like a rock climbing specialist. I was not totally sold on the idea that you could that it would be, not that you couldn't do it, but that would be very difficult to build a whole practice around just treating rock climbers. And at least for myself, and when I started working at this new practice, I was seeing a variety of different athletes, and then, climbers would come in because it's Boulder, and I think, I mean, not only my experience as a climber, like being able to talk the lingo, people really, inherently kind of trust you a little bit more, and you can relate to them a little bit better. But I think the big thing is just like when you're working with that clientele that you really like and really lights you up, you do your best work and people notice that. And so you connect better with people, you're going to give them just a better service, a better product. And so kind of the word of mouth spread from there. And like AJ was saying, a lot of time just being in the gym, being in the community, being your face out there, doing a lot of free work to to make yourself known in the community and try to give as much as you can before receiving. And so that's it. Just I went from being like skeptical to being now just treating primarily rock climbers, and it's really, really fun.
I guess that's me. I've been a climber for 30 years. I was a pro climber, and then I went to PT school, and I had 2 kids during that process. And I wanted initially to treat athletes postpartum, but in order to do that, you needed to understand pelvic health and women's health. And so I did that track first. And I worked at the University Orthopedic Center here at the University of Utah as a women's health and pelvic health specialist. And I was the only climber there at the time. And so everybody just started sending, they were like, we don't know what to do with climbers, go see Carrie. So I ended up seeing all the climbers there. And then Alex Puccio, who was at the time national champion, sort of grabbed me and was like, you need to come with me. And I ended up doing the World Cup circuit, and I got offered a space in a climbing gym. So I opened a clinic in the Front Climbing Club it was like 2015 or 2016. And that's where I really started working with climbers pretty significantly. Like I would troll the gym, and I would climb everything that I could, obviously. But it was funny to me that people would get injured on the same climbs. And so I ended up collaborating with the setters and the climbers and trying to figure out climbing injuries, because at the time it was not as much information, and Jared can attest to this, as there is now. So there was a lot of experimenting, for lack of a better word. And so just through that, people started to get to know me. And I think that's how my practice became actually a practice. Yeah.
Nice. And so now I'm just going to ask a couple questions. I think so we get enough volume of questions, maybe, one of the 3 of you just say, okay, I got this one, or I'll take this one. And that way we can get enough different questions. And everyone that's listening, whether you're on camera or off camera, you can also drop questions in the chat, and we'll try our best to kind of address those as well. Because we have about 104 questions that people submitted. And so, but we do want to tailor it to everyone that is here in person as well. So this was a question, actually, this was from a student who is becoming a physical therapist. And they said, I'm considering a career in climbing, or I'm an incoming first-year student, and I'm considering a career in climbing PT, which is amazing that like first-year physical therapy students are now like, I want a career in rock climbing. So their question is, any tips on getting started? Do one of you want to throw out any tips that you have for a first-year PT student?
Snag it. Yeah, I think always for all the students that I see, I think the biggest and best thing to do going into PT school is to really nail the basics. And if you're just coming out of school, really finding a good mentor or somebody to rely on, a good connection point, somebody that's been doing it for a while to bounce ideas off of. And the other part of it would be is just to jump in. I think that one of the biggest and best things that ever helped me was just reps. I mean, like seeing things over and over and over and over again, and getting different answers, and learning how to kind of take in all of that information and kind of synthesize it with like, oh, I saw somebody with a little bit of that, and then they kind of brought a little this in. And the more reps you get, the easier you can pick up on patterns, find ways to kind of get things rolling in the right direction for those people. So lots of reps, nail the basics, and find somebody you can trust.
Now, this is an interesting one. Now it's coming from a physiotherapist. So I guess physiotherapist or physical therapist. As a current physiotherapist wanting to start treating climbers and finger specific injuries, where do I start to gain experience? And this is interesting because, you know, in physical therapy school, typically we aren't trained as much in the hand, wrist, and fingers. And so, yeah, anyone want to jump on how to get experience, or maybe even how you got experience with, you know, treating finger injuries? Because if you're going to treat climbers, you have to be able to treat injuries in the finger.
Patrol the gym, like Carrie said. Go hang out by the hangboards. Yeah.
Yeah, I
Evan,
mean,
do you want to take that?
Sure. Yeah. I mean, you know, for myself, yeah, I mean, I'm right with Jared, where you get little to no training on hands. We just kind of like gave that up as physical therapists and gave that to either OTs or pure hand specialists. And so, you know, for myself, just looking at as much literature as you can. I mean, honestly, there's a lot you can learn just from like watching YouTube videos, just to kind of confirm the biases that you've kind of figured out with some trial and error. Jared has a good course on treating finger injuries that you can do online. And a lot of it is a bit of trial and error. I've gotten a little mentorship from hand therapists, but yeah, the resources out there are pretty limited. And so just trying to use kind of like a multimodal approach, just trying to figure out as much as you can in all these different areas. And then, yeah, the more I learned about the hands, the more I've started treating, you know, like up the chain a bit more, like looking at elbow and shoulder, thoracic spine function, things like that. And so, yeah, it's a bit of trial and error, and trying to work with the limited resources that are out there for physical therapists.
If you don't mind if I piggyback on that for just a second. Climbers have pretty specialized injuries in the hand with comparison to general population, especially that would go to hand therapists. So I think as a climber, you already have specialized knowledge for how we use our hands, which is very different from anyone else anywhere. You know, the injuries that we get are very specific to climbing holds, the way that we use our hands when we are grabbing holds, or how we train our hands or choose to not train our hands. Different, you know, if you are a climber, it is easier to understand what's going on with a climbing finger or hand injury than probably any other specialist out there. So trust your knowledge as a climber.
Yeah, I would agree. Just like and piggyback on that, like a lot of the hand therapists who have a lot more extensive training and a lot of other injuries to the hand, I still will see people who came to me because they didn't do as well in physical therapy there because the therapist didn't have that understanding of climbing and were underloading them and didn't understand the difference between an open and a half crimp. So yeah, I agree with Carrie that we do, even if we don't have as much formal training in a lot of these things, we are kind of the experts when it comes to climbers.
Definitely.
So I'll ask a few more questions kind of as climbing specific PT. And then I think as we go along, we'll start narrowing it down because there are quite a few clinical questions as well that are interesting too. And so we can do some of those. And then there's some specific questions. Some people, I just have a couple private chats and some questions on the board to, you know, maybe one or two of you specifically. And so we'll kind of go in that direction. But still on the general topic of being a climbing PT, this question was, could you please talk about strategies you may have used to market to this population? Basically, get more climbers in your clinic / practice. And I know that each of you are at the stage where you likely don't need to market. Climbers are finding you. But are there any ways that early on that worked for you that maybe other physical therapists, physiotherapists, or medical practitioners listening can use?
Yeah, I'll take that one. I think at first, I think you have to decide what your goal is. Do you want to be busy? Do you want to only see climbers? I know that, you know, I think it was maybe AJ, that was saying that a lot of mountain athletes are also climbers. And so for me, I knew the population that I wanted to work with, and I was okay with building the practice slowly, albeit starting in a climbing gym was a really easy way to kind of jumpstart that career. But I purposefully chose a space that was away from the, I'm like upstairs in the back of a building. It's not obvious where I am. If you know, you know. And so I went 100% at first with word of mouth. And my goal was essentially to put myself out of business. Like I wanted to fix everyone. That was my goal. And if I didn't fix them, they probably weren't coming back. And they were definitely not going to tell other people that it was a good experience. And so my whole like marketing scheme was just to get the appropriate clientele in the door by doing a really good job. It was nothing that was specifically targeted. You know, at first I didn't do Instagram. I just like taught classes and got my face out there as much as possible. But things have changed.
Yeah, and I think before anyone else jumps on this one too, I had a private chat that I think builds on this as well. Is you know, Carrie's talking about how it's like, okay, I'm focusing on when they're in the door. I'm giving 110%, and that sounds like, okay, that builds a word of mouth practice. Has anyone had, this was a question from Evan in the chat, are there any volunteer or free, in quotes, work activities you did to gain a patient base? Have any of you used that type of strategy?
Yeah.
Yeah, you want to go, AJ?
Yeah, so the clinic I work at, we're about 1.5 miles down the road from the climbing gym, and a previous PT that was working there before me, who was pretty active in the climbing community, had done some stuff there. And I think we kind of after COVID, we started doing a monthly something. Usually we do like a finger strength testing night, an injury talk, or like a free injury screen night. So really any avenue that you can get to get your face in front of people as you're getting going, and it allows you to get reps, allows you to see people understand who you are, what you see, what you do, who you specialize in. I think that's really valuable for that part of it. And again, so yeah, all that our clinic does is free. And it usually gets really good response and attendance. And then from there, people tend to, talk. And if you do a good job or understand what to do, and if your people are doing well, then they're gonna have that word of mouth referral.
And this was another question piggybacking on this, because I like these different themes. This says, how are you working with climbing gyms in regard to climbing on the actual wall? So this seems as though, like, once climbers are in, do they have access? Are you able to watch them on the wall? Do you have footage? Do you have, like, what do you have access to, and do you go to gyms? Does anyone want to jump on that?
Carrie, do you still work at the gym, Carrie?
No, so I left the gym in I think it was 16 or 17. It's been too long.
Mm-hmm.
Evan, do you have access to a gym through Mend, or are you guys in a regular setting?
Yeah, we're in a regular setting. So I have like a hang board and, a lot of like climbing specific equipment. But yeah, with that, I, actually it's interesting. Our specific insurance, I think it would cover us to like go to the climbing gym, but I haven't really explored that. I don't know how the climbing gym would feel about that. You always got to get those things covered with insurance, but yeah, I would say like I do a lot of video footage. So I have majority of people, maybe not all, but definitely anyone who's going like a little bit slower in their return to recovery than I want them to, or especially if they're kind of that like more motor control type patient who you probably suspect has some kind of movement errors when they're climbing. I'll have them take kind of like as much footage of them climbing as possible and just review it with video form.
Yeah, definitely. I do the same thing. Lots of video analysis.
Yeah, so I might be the only spoiled one. We have a wall in the clinic I work at, and I haven't I coach at the gym. I don't do any PT there, but also with a lot of the climbers, I coach remotely, a lot of video analysis and video stuff, or just learning through that. Actually, another individual is on the chat here. Todd is a coworker of mine, and he's treated climber at the climbing gym. So I think, like you said, it's kind of coordinating, and we have a good relationship with the climbing gym to understand how that works and really sussing it out with the insurance company. But I know guys like Kevin, Climb Clinic, who are in the climbing gym. I think that's a pretty valuable tool. And again, meeting people right where they're at is important in understanding. And so they're like that one move and you can go straight out to it, or, figure out and really help them through that way.
Here's another question. What are your most important services you feel like you can offer to the climbing community? What sets you apart from other providers? I think the context of this is, someone that's looking at, maybe you can say yourself, or maybe a recommendation you can give to somebody that's building a practice. But I'm assuming someone would be seeing a lot of patients with orthopedic conditions. Are like, what can help me set myself apart to see more and more climbers on my schedule? Any thoughts, any of you on that?
I think, especially if you can just familiarize yourself with all levels and styles of climbing. So that means, if you've never trad climbed, go trad climb. Talk to the community. I mean, the climbing community is a huge community, and specifically it's a community. And we all have this love of climbing that brings us together. And so the more that we can talk about it and share the same language, the more communication back and forth, either ways for you to teach them, they teach you sometimes, go get on the boards, go Boulder, or, just sort of trying to understand where people are coming from, makes it's that added modality that you don't get to use in any other setting is climbing. Like, you get to prescribe climbing.
Yeah, I think you're absolutely.
Okay, jump on it.
Yeah.
Go for it.
Yeah, I think you're absolutely right, Carrie. One of the big things that I think we see a lot of the upper level individuals in the PT world, or the athlete, or the PTs treating climbers, is the ones that are good and get a lot of the recognitions are the ones that are able to make climbing athletes better while they're injured. You need to understand, like, I can rehab your finger and load your finger, but how can I make you a better climber at the same time? How can I modify your programming? How can I structure your training? I think as a somebody who wants to treat climbers, you need to understand, like Carrie said, where this person's coming from. So again, I feel very fortunate to have been able to climb all over the country, have a lot of good understanding, have a lot of connection. I can talk to people about specific climbs or specific moves and places, but also I can talk to them about their training. Like, where are you going? Where you're focusing on? How can we modify your training but keep you training? And so being able to understand where that climber is from, going from hanging on a no hang device with 10 pounds and an open hand crimp because their finger hurts, to knowing what it takes to get them to be, projecting their whatever grade it is for them at super high levels, and being able to carry them and guide them and structure something across that continuum is, I think, extremely valuable when working with climbers, because more than anything, they want to train. to their betterment. Yeah.
Sometimes more train than climb.
Yeah.
So this was a question I got a couple of questions ahead of time, and then Anna just sent me this in the chat. So I think this is rather relevant, but this says, have you had experience with virtual sessions? And if so, how's it been with client buy-in and speed of recovery compared to in-person sessions? And there's another question kind of ahead of time, is like, how much telemedicine do you do? So I don't know if any of you want to speak to, if you or anyone that you work with utilize telemedicine for climbers, but I'll open the floor up for that.
I do about 30% remote consults, and most of them are functional impairment based. So it's more like coaching them through an injury rather than giving them like ways to treat themselves. It is sort of like they're treating themselves. Yeah. I don't know where I was going with that.
Yeah, I tend to
Yeah, go.
I will also see some people for some remote consults, mostly consulting them and their coach on how to modify their climbing around what they're dealing with, and then maybe helping them find a starting point of loading. And hey, like, we can back this off, modify here.
Mhm.
I actually find the remote consults, I think they were great because it makes the person shows up with the understanding that they're going to have to do something on their own and take ownership of their care and their rehab and their activities. Whereas I think sometimes in a clinical setting, people tend to come in and want things done to them. And not that there's anything wrong with that, but I think there's this over reliance then, or over dependence on, say, fixing somebody rather than helping them and guiding them through the process. And I think in a remote telehealth situation, people come in with the understanding and the desire to put that energy into it. And I think that's like one of the key things to them actually getting better.
Yeah, that's great. Yes.
Jared, I think you're
Maybe,
muted. Buddy.
I saw that. Yeah. So maybe we'll do one more global kind of PT question, then we'll start diving a little bit deeper. So let's see. Maybe let's do. Okay. So this is one that's interesting as far as what is it? This, I guess, is merging a little bit global, but it says, what does an eval look like for a climber aside from the basics you do for everyone? So kind of think like, I'd say if you're seeing a climber, like what are the things that you make sure that you do that kind of fit very specifically in climbing specific PT? You're like, okay, this is something that I typically will do with climbers that you wouldn't do with non-climbers. And I don't know if maybe each of you kind of, I know it's a vague global question, but I'd be interested to hear each of your answers anyway.
Yeah, I'll jump in. So I think I'll take one piece because there are a bunch of things that we could say here. I'll say I always ask about goals, because everyone has different goals, whether it's grades or different styles of climbing that they like doing, or it's not chasing grades. Everyone has a specific everyone has an idea in mind of what they want climbing to look like for them. It may be specifically goal driven, or it may not be. And so that's really how we're going to change and structure a rehab program. And then also getting a good understanding of just like what climbing looks like for them when they are climbing. Are they training all the time? Are they just going to the gym and having fun with their friends? How important it is for them to be going to the gym and having fun. And even if they're doing something simple, just them getting to the gym is really important for like their social life and their mental health. And then really getting a sense of who they are and how motivated they are in terms of how much they will listen to you in terms of your return to climbing program. And so I will ask every patient, you'll get a sense with people who are really like, okay, when can I get back to climbing? When can I get back? And I'll ask them straight up. I'll say, I want you to be very honest with me. If I tell you to not climb for the next 2 weeks, are you going to listen to me? And, they'll give me a very truthful answer. And usually it's, no, I'm not going to shut it down. And so, it just kind of changes the conversation and it changes the way we start that initial treatment program. So you really want to understand like who that person is and how they experience climbing.
So here's a question: common pathologies / injuries that you see with climbing and treatments used, because we know that there's data and research that's available about the most common climbing injuries of someone going into a general practice, but the ones that you see the most, what if you were to kind of percentage breakdown body region? I'd be interested actually for each of you, if you want to just say what's the most common body region, and then what's after it, or you can even rank them. But who wants to jump? All right, Carrie, go for it. Number one, shoulders.
I'm gonna back that up actually. If you look at the year, it's different. So not just like 2023 versus 2022, but like the seasons.
Yes.
There are seasonal injuries, and right now it's shoulders. But 3 months ago, it's always fingers. I tried to say no, that was November, and then I almost said no, that was in Jan. No, okay, it's always fingers. So maybe fingers, shoulders, and knees. Those are my top 3.
Yeah, I agree with Carrie. I think fingers are kind of a constant in and out. I live in Bozeman, Montana, so we have a solid 6-month winter, and it tends to be training season right now. And it's been about 2.5 to 3 months of people inside climbing now. And right about here is when we see people. I see a lot more finger injuries because people have been just trying to slay it on hangboards or the campus board and ramp it up, and there's just been a ton of volume. Shoulders for sure. In fact, sometimes there's like 3 guarantees in life for every climber, death, taxes, and shoulder pain. I think those are pretty consistent things almost no matter what. You're always kind of managing some degree of shoulder pain if you're a climber. I think with the new style of setting, I'm seeing more and more hamstring injuries.
Somebody just chimed in and said, no, wrists are definitely there. They're just not as prevalent. Yeah. And I think often people with wrists, they just, they assume that it's just a little thing and it's going to go away. And so that also might be occurring more often than we see. So we might be a little bit biased.
Yeah, I'd say for myself, probably ballpark it, probably 30% fingers, 30% shoulders. And then below that, elbows, definitely some wrists, and decent amount of neck pain. Actually, probably see less knee pain, interestingly, compared to you two. But yeah, lots of neck pain and like thoracic spine pain.
This is a good question. I'm going to pitch this to Carrie because I know, Carrie, you have a great answer for this. We're going to dive more into clinical components. But how would you confirm a pulley injury if you don't have access to sonar or ultrasound? So I thought that's a great question because we're very lucky to have an expert on that who's peer reviewed. So Carrie, what would you say? How would you confirm a pulley injury if you don't have access to sonar?
Oh, well, so first off, I don't actually use ultrasound. I've been doing it for a long time without ultrasound. And so I feel very confident in my diagnostic skills in that sense. They're not fully diagnostic, of course, but there is a schema for in the Journal of Hand Therapy. It's a potential classification schema, and it's really easy to perform, actually. Has 4 different variables. It's active range of motion, palpation, so if there's pain. There are, like, do they have pain during ADLs, or is it with movement? And so it's kind of sectioned out into that. And then you also have resisted tests. So is it affecting their strength, or is it just painful? And that way you can classify it based on severity. So you've got mild, moderate, or severe, and you can prescribe exercise appropriately or supportive measures appropriately, and you can actually track them throughout. And once you have that initial assessment done, you have something to base all of your further testing on. So you don't really need ultrasound, to be honest.
All right, we have a couple other kind of clinical questions. This one's interesting. Maybe one person can answer. Related, and I guess I'll summarize this one a little bit, but basically it's asking, related to elbow pain, whether medial or lateral tendinopathy, is there any pearls, tips, tricks that you have related to rock climbers that you can that you've learned along the way?
Go ahead, Evan.
Oh, I was just say, all about load management with these folks, finding the specific movement that does cause their pain. So oftentimes it'll be someone loading those lateral or medial elbow tendons eccentrically, like if they're crimping and like lowering down off of it, whether it's that or whether it's with a pinch grip or with crimping. All these different forces will kind of load those tendons a little bit differently. And then when you're designing their treatment program, just really dialing in that load, kind of being really familiar with the literature on tendon loading and treatment, understanding, giving them an understanding of what they should expect. So you're going to do this program on your own. and I'm going to be, here's your guide, but this is what you're going to expect. And if you get this response, you're gonna, I mean, well, you want me to get like a little bit specific, or should I keep it general?
Go deep.
Yeah, okay.
Almost everyone here is a clinician, so go deep.
Cool. Yeah. So, I mean, just in general for like those tendon rules, get really paying attention to what those symptoms are the following day. And so, you know, I think a decent amount of the literature kind of pushes us to like not have any pain during. But I think for more of the sporting athletes and especially climbers, I'm totally fine getting them a little bit of pain when they're doing their loading, whether it's the extensors or flexor tendons, and then just giving them a good understanding. So I always use like the green light, yellow light, red light system. So if you load your tendon the certain amount and you're paying attention to the sets and reps, just your overall time under tension, and you're getting increased pain the next day, then we'll call that a red light, and you want to take an extra day off and then decrease the load during the next session. The yellow light is if your symptoms are similar or equal to the day they were before. So you can test yourself and do some movements and say, okay, that feels about the same as it did, kind of unchanged from the day before. That's your yellow light. Kind of proceed with caution and keep things at the same level and load. And then the green light being if you get reduced pain that following day, or later that day, then you can go ahead and dial up the intensity or volume of that loading. And so just giving them a good understanding, and then I'll just ask them, you know, how many times did you hit the green light? How many times did you hit the red light? And they really get it, and they can kind of self-manage moving forward. And especially because these injuries do tend to be recurrent, they have that knowledge ready to go. So when it comes back again, they can just kind of jump right back into their same loading program.
Evan, are you also giving them climbing, any limitations or anything associated when you're doing loading, when you're prescribing loading?
Yeah, definitely. So again, I'll kind of cater it a little bit towards, you know, the people who are like really obsessed with climbing and they need to climb. That means, you know, if we have our different knobs, if you're going to climb more, you have to decrease the loading that you're doing in physical therapy, and the recovery is going to take a little bit longer. But if you're okay with climbing a little bit less, then we can increase that loading in physical therapy, and you probably have kind of faster results. And I kind of have them really prioritize the loading program for like the physical therapy rehab. But I'll also kind of follow those same like green light, yellow light, red light rules for their climbing as well. So you have to kind of take into consideration kind of the total time under tension of their climbing and the loading program that they're doing, because usually they're doing it simultaneously. So I'll just kind of have them, I'll kind of pay attention. I'll have them be mindful of the number of climbs that they're doing and the difficulty, and kind of combining those and using that as another data point to decide whether to progress or regress or maintain at the same level of load.
Here's another question. This is more in reference to a specific type of treatment, but it says dry needling is gaining more popularity among clinicians and patients. Where do you see dry needling going in the future? And dry needling is also, as a physical therapist, some of that is based on, you know, state and practice act. But I didn't know if anyone had a thought or bias on dry needling in general. And you may or may not practice it, but if you have an idea of where that fits in the future.
I'm a little confused by the question. The future of it implies that it's going somewhere that it isn't already. And I think it already is a very good tool in your toolbox for treating injuries. Hopefully it continues to be so, and more PTs throughout the country in all the states can do that. That's good.
Yeah,
I think for myself, like using it, you know, using what it's designed for like primarily myofascial pain. I think a lot of times people will be kind of like needling too much because it is their bias, and it can kind of give a general pain relief response in the short term, but kind of using it as the tool of primarily treating pain coming from muscles. And yeah, I would say maybe in the future, I could see it probably being a lot more useful for things like pro-inflammatory responses for like tendinopathies, or, you know, chronic like connective tissue problems that need like a pro-inflammatory response.
Let's cycle back on the elbow. I think AJ, did you want to add something?
Yeah, I can jump in both. I'll piggyback here on the dry needling thing though, real quick. And I've been dry needling now for almost 10 years. And I think right away when I started doing it, it was like I did it a lot. And I think the longer and longer I've been in the PT profession, the less and less I try to use it. It's a great tool, but I think we kind of I think some people rely on it too often. I think it's got to be that kind of right dose, right person, right situation to help get them going in the right direction. But I personally fall back on the bias in my personal opinion of it's difficult to treat active issues with passive treatments. And so that, again, totally my personal bias. I definitely use it and I will use it, but I am using it less and less and more sparingly as I am practicing. But yeah, real quick to jump on the elbow thing. I think one of the big things that really helped me start seeing a little bit more success with elbow tendinopathies is really getting a good understanding of where that tendinopathy is along its continuum. Jill Cook and Silbernagel and Durham all have really good articles about reactive on degenerative, degenerative on reactive, all that kind of situation. Understanding where that tendon's at along the continuum will help you understand how to dose it and how to treat it and how to, like Evan did a great job of laying out, how to guide that athlete on understanding what they should be feeling and when they should be feeling it. And I think Jill Cook said it with tendinopathies, if you're not feeling it, you're not healing it. And so getting them to understand that they should be expecting some pain and giving them that up front that, hey, you are going to feel something and that's okay. Here's your guidelines, here's your baselines, and just really giving them that key information puts them in control of it and also allows them to be more comfortable with that. And just the last thing is I would say is with any tendon or any tissue, we need to try to remember to load it through the strength, the continuum. And so one of the things that I've been doing more and more that I think's really helped is moving away after a while from like long duration isometrics into isotonics. And then we have to think, we need to load this plyometrically, take it through the whole continuum. And a lot of times I've seen taking athletes who have like a really chronic tendinopathy through that continuum 2 or 3 times over the course of 6 to 9 to 12 months will finally kind of get them out of that whole cyclical aspect. But I think if we're just loading heavy and slow, we're missing a big piece of getting that tissue healthy, because if we look at how athletes use those tendons on the climbing wall, it's not like that. So don't forget that other end of the spectrum, that velocity or that speed component can really make that kind of change in some tissues for that.
This was a question Todd dropped in the chat. He asked, how often do you see youth pulley injuries? I know that, growth plate stress fractures are more common, but do youth pulley injuries occur, or do you commonly see them, or have you seen them at all?
I've never seen a youth pulley injury.
Nope.
Yeah, I don't.
They just don't happen. They're
too
still made
soft.
of rubber, and
You've
for
never
the
had a
most
kid
part,
report
and they're like
pain?
dilted. Say what?
I said you've never had a kid report like pain on the dorsal side or on the
Yeah, but you
pelvic
got to
side?
do differential diagnosis and make sure that it's not a little tendinopathy going on.
Yeah. Okay. I was just curious. Yeah, if you never have. Yeah, it's pretty rare, I think.
Yeah. Or if it's maybe lumbricals. Yeah, just like hand tightness. Because they're probably like all the time. Just crushing it.
So we have about 10, 12 more minutes. And so I'm going to shift gears now. We've been going really specific. I'm going to kind of ask a certain question to each person because we had some questions directly to the different clinicians. This was one from Dave in the chat to Carrie. Do you see much correlation with pelvic health in climbers? And I think this is early on that he dropped this in because you had mentioned that you had started, within pelvic health itself. So is there anything you can speak to just regarding pelvic health in climbers?
I think one of the greatest aspects of being a pelvic health therapist is just understanding the core and understanding lumbopelvic motion and how it relates to core tension throughout the body. As a practitioner, I do core work all the time. Like if somebody comes in with a shoulder injury, I absolutely treat the core. And in that case, I look at how they're using neutral spine, articulated movement, anything where, you're combining kind of that ring of the rib cage to the ring of the pelvis. and how we transmit tension throughout the body. So I think from a pelvic health standpoint, talking about pelvic floor, even with your male clients sometimes who aren't able to generate power, often it's actually through the shoulder or through the hip, as with like a knee injury or an ankle injury, is really important. Like if you notice that within their movement, they're sort of not transferring that like power through their entire body, it's oftentimes a moment to talk about the core, talk about the pelvic floor, and talk about how we generate power motion in the body.
This one's specifically for AJ. Curious to learn from AJ how he pivots from being a Climb Strong coaching role to a PT role when athletes athlete gets injured logistically. And AJ, maybe this helps to maybe give a little bit of context of kind of your coaching role as well.
Yeah, so I think for me, a big part of it is in my fundamental philosophy. I think I'm coaching every patient that's in the clinic towards their goals. And I guess more specifically to like, if one of my athletes that I am coaching as a coach for their performance stuff, it gets some kind of pain complaint. To me, it's, I'm just happen to be their coach who has a little bit more specific knowledge at that point. Again, I'm kind of helping them understand getting information from them, helping them understand what they're feeling. I have had some athletes who have some neck complaints and they'll get stuff in their down their arm, and I'm like, hey, you got to go get this looked at. I'll help them remotely where they're living, find a PT that's close to them. But if they're dealing with like, oh, my shoulder's a little twingy or a little tweaky, then I'm, as their coach, help it's going, okay, let's avoid maybe some vertical climbing, let's get it a little bit overhanging, let's double down on some specific cup or scap stuff and just kind of helping them understand what they're feeling and helping me, and I'm helping modify their training on the wall, their strength training program. So, but I do that kind of in a very similar fashion for my patients that I see in the clinic who are skiers and have ACL injuries, or runners who have calf complaints. With my background in running, I will structure them 4 to 6 weeks of running if they're gearing it up. So I think it's just a unique aspect of the care I'm able to provide to take them through that continuum at that point.
This was one that was just dropped in the chat, and this kind of piggybacks on an earlier discussion with movement. And we were talking about, watching video footage of climbers and the importance of it. Do you have any global opinions / strategies for discussing and addressing movement faults that you see from patient video footage? And maybe I'll broaden this up to maybe anything related to what you do with footage from the patient. I think would be interesting context for people to hear. So whoever wants to speak to that. It's very open-ended. Yeah, go for it.
Yeah, I personally, again, and this is my opinion, I think I struggle with the whole fixing movement component to climbing. I think there's a very specific set of skills that a climber should maybe really focus on and try to develop. Again, controlling center of movement, using momentum, good footwork, placing their body in space right, being able to read a climb. And again, as this is contextual and very situational, but I'm always hard pressed to tell somebody that they're moving poorly. And I think this for me stems a little bit from the running world of stuff. And I watch people who run and win gold medals, and they have some of the worst running form I've ever seen. And I'm hard pressed to probably tell that individual they need to move differently. And I think climbing is a unique sport where we're consistently every second move to move on the climb are adapting and changing given our unique set of physical ingredients and or physiological components. So I think there's movement efficiencies, which I personally find that I am fundamental and kind of just work back into the global strategy of climbing skills and drills, with maybe a little nuance depending if they have one or two specific things. But I'm hard pressed to ever tell anybody that they are moving or positioning themselves wrong and they need to do it in this right fashion. That's that would be my take on that.
To just because I work so much with movement, it is as a movement practitioner, like that is one of the things that I focus pretty highly on. Strength is very important, loading is very important, but movement matters. And for me, I love watching movement. So it's just one of those things that's very inherent to my practice. I totally agree with you, AJ. I would never really tell somebody that they're doing it wrong per se, especially if they're having success with that movement. It could just be their style. Like some people climb with their shoulders up around their ears all the time, and they don't have neck or shoulder injuries. But if they're coming in with something that is chronic and we can identify something within their climbing movement that they're doing kind of habitually, then absolutely, I want to find that. I think that's part of the initial evaluation or assessment when somebody comes in is, I think people are really used to glossing over what they do in climbing when they're coming to see a physical therapist or a physio, because they're not used to having somebody actually listen to them and hear what they're saying. And so I always tell them, tell me everything. I want to know how many times a week you're climbing. What's your warm up? What do you climb? Give me numbers. What's the hardest thing you do in a day? What's the easiest? What do you like the most? When do you feel things? What do you enjoy? What do you dislike? What are your strengths and your weaknesses? And just through that, you can kind of take their history and you can watch their motion and think about the injury that they're coming with and think, well, could this actually be coming from their climbing? Should I assess their movement on a climbing wall? And I think that's when you kind of decide, okay, I want you to, get on a vertical climb, a roof climb that are both V3. I'm just throwing them out there. And how are they different for you? And then look at the movement as well. Like, where are they losing their power? What do they rely on the most? I don't think you have to actually change their style per se, but altering how sometimes people don't breathe when they climb. Sometimes they're just redlining it all the time. The moment that they get on the first warm up, they're holding their breath and they're pulling as hard as they can. And so sometimes just having that movement discussion can make it easy on you as far as how am I going to treat this thing that just walked in the door.
So I think we'll go ahead. We'll wrap things up. This has been probably this rapid fire questions. I tried to get as many ideas and thoughts in here. I think for each of you to kind of bring everything home or wrap things up, if you had a piece of advice for anyone who's listening or watching, of how they can see more climbers, how they can become a part of the climbing community, how they can load their schedule and become a climbing specialist, because the real topic here is climbing PT. And so there any advice that you can give to try and take whoever's listening and make them more and more of a climbing PT based on your experience?
One thing, aside from this, get good at being a PT, find a good mentor and become a really good PT. But I would say the biggest thing for my marketing is don't be afraid to do a lot of free stuff. Really give before you try to receive. Don't go in to any kind of marketing meeting or outreach thing trying to just take. Always be trying to give, always trying to give selflessly, and you kind of show up a little bit differently and people gravitate towards that a bit more. So definitely give as much of yourself as you can. I guess there's that saying of I quit my 9 to 5 to work my dream job and now I work 24/7. It's a little bit of that at first. There's a lot of hustle, a lot of grind, and a lot of free work, but it's totally worth it because at this point now it just starts rolling with the word of mouth, and is well worth putting in all those hours. It's fun too.
Teach clinics. There are lots of opportunities out there. I know that I think both Evan and AJ were mentioning that they work with climbing gyms, and gyms are always looking, for that value added point for their members, like going and having a clinic or going to a festival and teaching at a festival, can help get the word out too.
Yeah, I think I echo both of those. Just be a face, be open in the gym, let people know who you are, but also really get to befriend the people who are at the front desk, and maybe the coaches in your local area, because they're the ones always looking for that alternate resource. It's almost like when you're trying to get referral sources from other docs, and I think sometimes the front desk, the setters, the coaches, they're really good referral sources, because in order for those people to keep coming into the gym and paying their memberships or paying them as coaches, they need to be healthy, and we can kind of help keep that cycle going.
Well, huge thank you to Evan, Carrie, and AJ. And if you're here too, just drop a thank you as well in the chat. This has been great, and just to get different ideas as everyone here is listening and trying to continue to build your practice. And I wanted to thank each one of you for being out, and each one of you has a different perspective and it's coming from a different environment. And I think that's the power of having some of these panels. So thank you for coming on, and hopefully we all get to climb together at some point again.
Yep. Thanks for setting up, Jared.
Thank you so much.
Absolutely.
Jared.
Yeah,
This was
thanks.
fun.
All
everyone.
right.
So
So
great
we'll
to
hang
meet
on.
both of you too. Awesome.
Absolutely.
I'm going to be contacting you with questions.
Likewise.
Nice. I might have answers.
Yeah.
All right. Thank you, everyone.